Welcome to another episode of the AUA University podcast, where we focus on practical, evidence-based education you can bring into clinical practice. I'm Dr. Mark Gonzalgo, professor of urology at the University of Miami and chair of the AUA Office of Education. Today, we're tackling one of the most rapidly evolving areas in endourology, suction-enabled ureteroscopy for kidney stone management, with a focus on the CVAC system. Stone disease continues to increase in prevalence and complexity, and many of us are re-examining how we achieve stone clearance while minimizing operative time, intrarenal pressure, and the need for secondary procedures. I'm thrilled to be joined by Dr. Karen Stern, Associate Professor at Mayo Clinic, Arizona, and Program Director of the Endourology Fellowship. Dr. Stern's practice focuses on complex stone disease, and she has been at the forefront of adopting and critically evaluating suction-based technologies. Karen, welcome, and thank you for joining us.
Thank you so much for having me.
So to set the stage for our listeners, when you look back over the last 5 years, what do you think has changed most dramatically in how we approach kidney stone management?
Yeah, I mean, this is such an exciting field. Over the past even 2 to 3 years, we have made so many changes in ureteroscopy and the treatment of stones. Things that we could only imagine 5 years ago are now commonplace and pretty standard of care. And a lot of that revolves around suction and aspiration. So sheaths, scopes, all of that, it is this rapidly evolving space that has made a huge improvement to patient care.
You know, as someone who doesn't routinely perform these types of procedures, it is always fascinating to me. I mean, it's almost as if suctioning now is not just an accessory, it's more reshaping, procedural goals and endpoints. And, to that point, when urologists hear, the term suction ureteroscopy, they often lump everything together, but these systems are fundamentally different from my understanding, right? So what suction technologies are available today and how do they differ?
Sure. So there's two sort of main categories. So there is what we call fans, which is flexible and navigable ureteral access sheaths. So that's your typical access sheath that we used to use, plus a flexible tip on the end. So that tip actually goes into the kidney and you can navigate it around to any calyx that you want. You use your regular ureteroscope and then you laser, and then that actually suctions out the dust around the scope, or you can suction out fragments as you withdraw the scope back into the sheath. So that's one part. And then there's what we call suction scopes, where the suction is integrated into the scope. And within that, it even gets a little bit more complex. So there are sort of two different categories. There's what we call DIS, which is direct in-scope suction. That's your traditional scope that has suction incorporated, and that the inflow and the outflow are the same channel. So you have your inflow, you laser, you turn off your inflow, you activate the suction, and it suctions out that same channel. And then you have the CVAC scope, which is a little bit in its own category, which it does have suction incorporated in the scope, but it's a different channel for the inflow versus the outflow. So while you are suctioning out, there's still this irrigation in there into the system. So you don't get that sudden collapse, and it sort of has these fluid dynamics that I think offer a better way to evacuate the stones.
That's a great explanation, and thank you for that overview. Karen, when you're choosing among these systems, are there any clinical factors that influence your decision on which one to use?
There are, and I know, in the stone world, it's this big like CVAC versus fans, DIS versus fans thing. And in the perfect world, and honestly, in my practice, I'm very lucky. It's not really an either or 100%. I think we need a world where we have both available. And so for fans, that is my traditional sheath that I use for almost every case. Like I never really pull the old school traditional access sheath. I use fans for almost everything. If it doesn't go through the UPJ, that's not a big deal. I just use it as a regular access sheath and don't open up the suction accessories. CVAC, it works excellently. I do use it a lot. I do save it for my bigger stone volumes. Most of that is because of the cost. It's a big scope. It's 12 French as well. So you have to reliably know that it's going to go through the UPJ if you're going to open up a scope of that cost. So I reserve it for my patients who are pre-stented, or if I think they have bigger caliber ureters with that larger stone volume.
Great. Whenever new technology enters the OR, the first question is always, how steep is the learning curve? I mean, how would you characterize this for any type of new technology, in particular the CVAC system?
It's really not that hard to learn. I mean, I work with junior residents who I would say within 2-3 cases are pretty experts on it. They're really good. And so the CVAC system is pretty easy to learn. It's a regular ureteroscope. You use it as you traditionally do. And then when you're ready to aspirate, you take out the laser bridge, you irrigate the fluid a little bit and then activate the suction. So there is a learning curve in that you have to be patient. And in your mind, a 7 French channel is like, oh, I can get out these huge stones. That's not necessarily the case. You have to be patient and learn to really dust before you start to suction, or else you might get frustrated with clogging. But the general learning curve, as soon as you learn the sort of pieces and how to use it, it's pretty short.
Okay, well, it's encouraging if you say a junior resident can do it. There might be hope for me still. Are there any types of patients that you might, say are more suitable for this approach for someone who might be in their early stages of the learning curve?
Yeah, so if you're in the early stage of the learning curve, I would not take the person with the staghorn stone and staghorn struvite stone, right? Like, I don't think that's setting you up for success. I think there's a learning curve a little bit in learning the ins and outs of the scope and how to keep it successful and avoid clogging and safety and all of that stuff. And while that's not a steep learning curve, there is still one. So when you're early on in that, I would take the patient with the 1 centimeter stone that's pre-stented, that came in through the ER, that you can treat. And honestly, that case will take 20 minutes with a CVAC scope. It's really easy. So patients who are not necessarily infected with sort of these medium-sized stone burdens would be who you should start with.
Okay, great. And, in using the CVAC system, do you have any practical, tips or tricks for the audience?
Yeah. So, which laser to use is a little bit user dependent. And I personally like the holmium with the CVAC system. The reason for that is if you popcorn, it gets stones to the perfect size to be able to suction out, kind of that 2 millimeter size. It's harder to popcorn with a TFL, easier to dust. So some people do prefer the TFL with it, but I like the holmium. That's kind of my first point. And then, they have this laser bridge, which you have to kind of finagle down every 30 seconds or so to make sure that that channel is not clogged. I do that. And then the most important thing is to listen for the audio clues. So you want to make sure that you hear that suction all the time. And if you're not hearing that, you have to worry about clogging. And so you have to just make sure and remind yourself all the time, hey, this is going and this is working.
Okay, wow. So it sounds like CVAC can certainly reward deliberate technique. It's not something that you can simply set and forget, right? I mean, this is something that requires active monitoring and just like any other piece of equipment.
It does. I mean, certainly more active monitoring than just like traditional ureteroscopy, but the advantages are that you can get out such bigger stone volumes in a much quicker setting.
Okay. Well, no technology is perfect, right? And urologists can be skeptical of things when they first come out. What's the case where you may have looked at a CT scan, you've thought about using CVAC and said, well, this is still probably better served by standard ureteroscopy or PCL, and why?
So my practice is really PCNL heavy. So there, in endourology, there's this big debate with all this suction technology. Is PCNL dead? For me, it's not. It's still faster than ureteroscopy, even with suction. So I think really large stone burdens, staghorn stones, anything over sort of 2.5 centimeters, to me is sort of more of a clear PCNL. But people who don't do a lot of PCNLs and aren't experienced with it, that may still be a CVAC case. But for me, that larger stone burden, especially dense stones and hard stones, are still PCNL. Traditional ureteroscopy, small stone burdens maybe, but there aren't a ton of stones that I would look at on a CT scan and say, oh, this was not going to benefit from any suction technology.
Okay, and with any type of new technology, there certainly can be cost consideration and value justification. I'm someone who has no idea what this costs, but for someone out there who may have limited resources, what advice would you give them when considering incorporating CVAC into their practice?
Yeah, I think that is probably the biggest concern. It is much more costly than any other ureteroscope. I mean, there are other things that go into it, right? If you do fans, you have a suction scope, you have a suction sheath that you have to pay for, and the suction accessories, and your disposable scope that you have to pay for anyway, or your reusable scope if you do that, and there's, the chance that you could damage it. So I would say, there are reimbursement advantages to CVAC. There is a hospital associated fee, I believe the C9761 code, that you get reimbursed a fair amount. So there is that. I won't pretend to be the expert in the finances of it, but I think if you work with the company, they are very good at kind of working through that with your institution. And I know a lot of institutions are really interested in advancing it and trying it because of that reimbursement code.
No, that's great. It's always a potential challenge when you're going to value analysis committee to try to justify purchase of a new equipment, and they have to do whatever it is they do to justify that purchase. I guess on one hand, you said if it's much faster, you could argue, you could potentially decrease case times and so forth. But I do think that's something that may challenge a lot of folks. And I think when it comes to clinical practice, I think, we still have to use judgment, right? That just because you have suction there, it doesn't replace thinking during the procedure. I don't know if you have any comments on that.
No, that's true. I mean, it's still not, stone cases are not simple, right? And you may think that they're all simple, but they're not. You have to use your judgment. You have to open up what's going to be the best for that patient. There are certainly cases where why are you going to open up a several $1,000 scope for an 8 mm stone? That doesn't really make sense. But for larger stones, and if you're thinking about cost analysis, it is faster. You could potentially do another case during that day. Or if you're decreasing secondary procedures, which we've shown is true with CVAC, then that's a huge advantage of the patient.
Cool. That sounds great. Now, look, if we fast forward 5 years from now, okay, where do you see suction-based stone management heading?
Yeah, I think even though we have made huge strides in the past couple of years, everything we have on the market right now, I think will almost be obsolete in the next 5 years. It's kind of interesting, in the OR 8-10 years ago, I'm sure that you were doing ureteroscopy and people would always be like, oh, wouldn't it be cool if there was like suction in the scope? And suddenly there's been this explosion of that, but it can be so much better. So there has to be integration of systems. So pressure is a big deal, intrarenal pressure, fluid management, all of these things that we're figuring out. And so I think the systems that are going to come out in the next 2-3 years are going to have integration of fluid, pressure, perhaps temperature, even laser integrated into it, just this fully integrated system.
Yeah, not to mention the digital scopes that are always changing and evolving, as well as, whether it's disposable or not. So, so here's a thought-provoking question for the audience to listen to so what do you think? Is this the beginning of the end for some PCNL indications or just a refinement of our toolbox?
I think it is a refinement of the toolbox, but a significant refinement. I do think that PCNL volume will go down significantly, but I don't think PCNL is dead.
Okay, great. Well, look, suction technology isn't replacing PCNL or ureteroscopy, right? It's potentially redefining the decision line between them, allowing us to treat more stones effectively and with less invasiveness. Dr. Stern, is there any last thought or words of wisdom you'd like to give the audience with respect to this new technology or just for stone management in general?
Yeah, I mean, I think stone management is just becoming so much better and so much more applicable to everybody. If somebody's interested in trying it, I would say, again, you don't have to pick one thing and say, that's the only thing that I'm going to do and I'm going to learn it. Try what you want, try different modalities, try different scopes, try different sheaths and see what you feel most comfortable with. There is a learning curve a little bit, right? So do several cases with each and see which one fits best in your practice and which one you think is best for your patients.
Dr. Stern, thank you for sharing your expertise and just as importantly, your practical insights. This was a thoughtful discussion about where suction ureteroscopy fits into modern stone management. For our listeners, a key takeaway is that technologies like CVACs are not simply incremental upgrades. I think they require a shift in procedural strategy, patient selection, and expectations. Thank you for joining us today. For more high-quality, practice-relevant educational content, please visit auanet.org/university. I'm Dr. Mark Gonzalgo. Thanks for spending time with us on this important topic. We look forward to seeing you again on the next episode of the AUA University Podcast.